One of the things we will face as providers in the years ahead is increased pressure on performance. In other words, a sort of era of accountability, being held accountable for quality, for cost, efficiency, and the safety of care. And as the electronic health record being one of the primary ways that we help those who deliver care to meet those objectives, one of the things that you find is increasingly there's too much to know for the clinician. And you find that the processes of care, despite having terrific physicians and terrific nurses, often break and don't perform very well. Processes such as transitions of care or following up on abnormal results. And in addition, there's a fair amount of quality data that is now being asked of the providers to generate in order to receive payment, but also to help public health purposes. So the electronic health record will have to become smarter. In other words, it will have to help those who deliver care make the right decision by suggesting diagnostic calls and treatment decisions. It will also help processes of care work better. In other words, let people know if an abnormal result has not been followed up in a period of time, or let people know if someone is due for a visit and has not been seen in a period of time, or hasn't picked up prescriptions. So increasingly we'll see the electronic health record, which for a very long time has been oriented to supporting transactions such as writing prescriptions or retrieving results, increasingly be intelligent by possessing rules engine, workflow engines, and other methods that enable those who deliver care to be as good as they can possibly be. Well, there can be a wide variety of challenges, and some of them go back to challenges we've had with the electronic health record over the decades. It's difficult to put these into the workflow and not slow the physician down. It is difficult to finance them. They're often very expensive and challenging to implement. So these difficulties, challenges of taking this very big, invasive system and implementing into the fabric of an organization that's delivering care around the clock is hard. In addition to adding the intelligence will mean that there has to be ways of keeping the intelligence up to date or current with medical thinking and current with medical practice. It also means that we have to help those who deliver care understand what these suggestions are and what they mean and don't mean, and help those who are managing clinical practice overall, like the chief medical officer, the chief nursing officer, know how to look at the data that is being directed by and generated from this intelligence and understand how best to continue to work with the clinical staff to improve care. Well, we see lots of examples of organizations that are doing this well and doing this right. The VA is doing a terrific job. My former alma mater, Siemens Healthcare, is doing a terrific job. We see a number of community hospitals that are doing terrific jobs, don't have quite the same academic background as a number of the more famous organizations. And the reason they do a terrific job, Mainline Health being an example in our case, is that the leadership engages the clinical staff in a partnership. And this is really probably the crux of it, the most important thing that you could possibly do. And in a very thoughtful and deliberate fashion, identify where the care needs improvement and go after those areas one at a time, or multiple in succession. So there is this never-ending journey. In a way, it reminds me of guerrilla war. You won't win it by any single battle, but 1,000 small and medium-sized victories will carry the day here. So those organizations that come together as a team, have terrific leadership, are thoughtful, really understand the processes of care that they have and how to improve them, and then apply appropriate tools and technology will do quite well.